Okay, another case study. This one is this is upper arch, and we have two areas to look at. In the upper arch, one is a fractured root from an older root canal treated tooth, and we'll look at where it fractures. And one of the recommendations, if your doctor's watching this, I have different opinions about it, but my opinion is my opinion, so I'm going to use it, and you'll see why I think what I think. So, one is an edentulous site. I'm not sure how he lost that tooth. I'm not sure if it was grafted. It was a while ago. He's interested in implants up in the front area here, but here's the root canal treated tooth that is fractured and has a concern about because there's swelling and things like that that's occurring. And what are we going to do, or what can we do to help him in that? So let's start with the root canal treated tooth here. And if we look at the slice view, right off the bat, when somebody has a lot of facial swelling and I see an x-ray right there, I already am suspicious of some sort of fracture in that tooth, especially with the post. I don't know if this is a full metal post. I'm assuming it is, but when you put a full metal post into a canal, a custom post and core, I highly don't recommend doing any of those things because it does weaken the tooth structure, especially where you don't want it, where the tooth becomes much thinner. And driving posts down into a canal when the root becomes more narrow is, in my opinion, not a very smart thing to do. I understand the biomechanics, but I never see, even without doing any post, if you have proper tooth structure, why you even need a post to keep the core or the buildup in there in the first place. You can pretty much bond it in, and that's pretty much well enough. If not, you just put your core in multi-rooted tooth here, into the couple canals, and then it would bond into those canals maybe a millimeter or two, eliminating any sort of need of drilling more tooth structure away, therefore weakening the tooth structure. So I don't recommend doing post, and if you're going to do a post, I would say stick with a carbon fiber post, have a little flex, but I do see these occurring from time and again when people lose teeth and the fractures midway through the tooth, and it's always at the base of the post. So looking at that, let's look at that. That's the tooth here, and there's a lot of distortion because of the metal, but we can see where the post right here is fractured, that root area. My problem is when something like that occurs and we're trying so hard to grow bone and maintain bone, this is impossible to try to really get that bone back. It's very much destroyed all across the facial plate here, creating a harder environment for any kind of bone grafting to occur. And then you have a lot of infected bone way down at the tip of the root that's causing problems towards the sinus and around this and that lingual root, because this whole entire thing is fractured across here. So, you know, it's a precarious scenario because of where the sinus is and the height of the bone and the tightness between the teeth. There's not a huge amount of room between the actual roots of this tooth and this tooth, and you don't have a lot of room for restorative qualities up here. So the patient's interested in implants, and after having a discussion, if you're going to go down an implant route, for sure this is going to require a socket graft upon extraction to try to get that bone to stay there and heal it through. And at best, let's say we get bone to about here. That means that we will have bone only from here to here. So we've got a decent amount, and if we look at putting an implant in there, that might be possible, which would look something like this if we were to put an implant in. But my problem isn't so much that I could be successful with an implant and I can do the sinus work and the grafts. My problem is that my base of my implant is way up here, whereas my base, let's say, to the natural teeth next door is way over here. So if we look at the actual bone height, the bone height around these teeth, the natural teeth, is more like this. Right? So what happens when you have bone connecting to an implant is that that bone now has to go from there to the top of the implant up to this tooth over here. So it's going to look like this coming across. Now, I'm not so crazy about that look, mainly because you've got the bone attaching to the implant here, but the bone is trying to support the tooth here, and that means that anything along the abutment to the crown, there's a direct path of bacteria that go down in there. And one of my issues here is that, is this going to pull the bone down away from the teeth to try to level out to the implant? Now, different implants have different effects. The different shapes of the implants actually really matter, especially in this case. So, companies like Bicon or Astra or small neck type of implants, I'm trying to think of some other ones. Maybe Neodent does this. They would probably accommodate this a little better than, let's say, an old Nobel Biocare or an older, wider Zimmer type implant where it's just an internal or external hex. Those are not going to be ideal for this site, and it will probably draw the bone down, whereas something with a narrow neck type implant mounts would accommodate this much better. So this is now where you got to get into the technical details of what you're really going to do here, and I feel the best thing to do is to just advise the patient that this is going to be at least a 2-bone healing event situation to do an implant in this case, and the expense is going to be well over $3,000 to get this finalized and restored, probably closer to $5,000. But here, this patient is missing a crown on a next door tooth that's root canal treated. So in this case, I was asking him about that, and he knows he needs to get that done. So I said, why don't you do a 3-unit bridge? We can graft the site if you want to maintain the site, and that'll maintain for a while. But you can do a traditional 3-unit bridge. You get a good effect, and also you save some money because you're going to be now dealing with something you already need next door. So the 3-unit bridge helps the edentulous site and the molar site from fracture here, and then you're just really doing a crown on this tooth. Unfortunately, that's your sacrificial lamb right here that's going to have to be a part of that 3-unit bridge. So when finances come into the picture, which they always do, you got to be realistic here. Patients typically like to see that the dentist is concerned about their financial health. And they also then realize that it's going to take twice as much money for one tooth, and then they still have to invest in the tooth next door another $1,000 for the crown here. So in this case, you know, the patient can decide both. I'm not against 3-unit bridges, and I'm not 100%, you know, bought into the idea that every site has to be an implant site. So the patient can make their educated choice and understands the long-term consequence. And if they have a problem with that 3-unit bridge 15 to 20 years down the road, they will at least have some bone available here. And if it's one of these teeth, then maybe they do 2 implants at that point. But at least it kind of moves things along for them in a matter of 2 weeks than 9 months. So let's look at the front area here. Let's look at how wide that bone is. This patient does have a constriction of bone. We see that with the lower teeth. So that makes me concerned about whenever you have a tooth that was extracted that is a has constriction in the bone, you're not going to have a lot of bone available for width. So here's the constriction. If you look at the bottom, it starts to constrict, and most of this is all tooth here and not a lot of bone structure around it. And the constriction's right here. And when that tooth was lost, you could see there's still a defect here. And on the tissue side of it, it looks like this. Let's see here. And you see that little dip here where the tissue comes out. And then it dips in. This is your bony defect. This is a difficult situation to try to deal with, making the gum line even when you put an implant here. So meaning I don't want this giant site. Is very difficult to control, and he must have had a space between his front teeth as well. If this is the midline of the teeth, he probably had a slight midline, but his teeth are very triangular. And doing an implant here, he's going to have a very triangular tooth coming out of here. The other thing is that this is a very yellow tooth, and I talked to him a little bit about the cosmetics. He's not so happy about having yellow teeth either. So either he does other crowns or veneers and an implant here, and then he's got this concern about the defect of the gum line. Luckily, his lip line is fairly low when he smiles, so it's not the biggest concern. But what I don't like is to see that we're going to have any problems down the road. One of my bigger issues is the implant success. The implant success relies on the quality of the bone here, and he's got a very lateral loading, flaring teeth. His teeth go more like this, and so the function of his lower teeth are come at much more angle, giving it a lateral load to this implant that's coming off, that's supporting that tooth. It's different than if somebody had teeth that were more like this, let's see, like this, where you're using them more in function like this, or if you grind, it's a little different, less chance of having a big lateral load. Here he's at angle like this, and that's definitely a lateral load coming right into the back of that tooth. So here's where you would be looking at doing the implant, right down the middle, right here, and that's a very hard bone and it's very thin. If we're to look at doing an implant there, we're not going to get the best implant size into that site. That's a very small diameter implant in very hard bone, and the tooth is going to be very long. You know, we're looking at from the top of the implant all the way down here, and what I'm going to do is actually rotate this picture so that we can see actually what it looks like. Let's look at this one here. And what I'm going to do is put this yellow line at the top of that edge right there. Okay, so we now can see this is where he had started with the other tooth. Look how hard that bone is there, and look how thin that is because of the constriction. He does have bone actually coming up along here, and he has more bone coming through here. So it's not the best situation here either. Let's see, there's probably bone about there, but let's take a look at that. So this isn't the best case either. He's got that lateral load here. And here's that tooth again. Let's go back to that. And that's where he's going to be. Like that. And now we can see at that tooth height here. Let's bring that in. 17 millimeters or so. Let's see. Yep. 17 millimeters on an implant here. That this is an 11 and a half. Now you could do a 13 or longer if you want to do a 16. Let's see. Is that a... can't see what the size is. My cursor is blocking it. You're still at a disadvantage of the height or the length of the tooth with the abutment relative to the length of the actual implant. When you have 17 millimeters coming off of an implant, you have two concerns here. The biomechanics are not in your favor. The hardness of that bone is not in your favor. The size of the diameter is not in your favor. And all of the stress is going to go right around that neck of this implant. So length won't matter as much here. It will matter, but the problem is that that implant neck is very thin. I've had a small diameter implant crack in a very similar situation, and the patient had a denture on the bottom, not natural teeth. So I'd be very wary of this one. The second thing is that the biomechanics are going to put a lot of stress also right here, causing bone recession around this implant right at that neck of that, causing possible tissue recession around that, exposing the implant, etc., etc. So this is a very poor long-term prognosis. Even though I could get an implant in here, the prognosis is very poor post 5 years of this being in function. Now, I don't know how this patient actually chews and eats, so this is a very difficult situation. And his other concern being a cosmetic concern across his front teeth. Now, he's got a space here. He's got a abnormal width here relative to this tooth here. Now, in this case, he doesn't have a lot of great amount of bone on this tooth. So what he is electing to do is once again do a 3-unit bridge here, which now we can strengthen it here. And if we want to do a double abutment tooth, we can do it across from here to here, so that now that supports that better. He has more of a cleaning issue, which, you know, as long as he keeps everything clean in the front, they do very well. He then now can support going across all these 4 teeth, get a really nice prosthetic. We know the gum line won't be an issue there because we're not going to disturb that anymore. And he'll get the cosmetic effect that he would like. So this is a tough call on whether you want to do implants or no implants. But in my opinion, what I don't want to see is somebody either in a cosmetic area or an area where they don't want to spend extra money for an implant when they need help next door to go through all of that. So I'm fine with the bridge work, restorative bridge work here. We solve a lot of problems, different ways going away from implants in these particular areas. So that's a good case study, and hopefully you'll join us for the next one.